Everyone, and welcome to another UK Hangout. Lately, we have been talking about all of the different trials for peripheral artery disease happening across the NHS, across the United Kingdom. Today, we are featuring Dr. Dave Bosenquat. He is in South Wales, and we are joined by one of his colleagues as well, Grace Young. She'll be up in just a moment, but so excited to have you both here. And thank you so much for taking the time and your interest in PAD. Sometimes when you're a patient immersed, in this disease, it's easy to think that no one cares, no one's doing anything because of where you're at, suffering from this disease without any cure at the moment. And so it's really nice to hear that there are people that really care across the UK, and they're fighting for life and limb on a daily basis, doing the research, hoping to create the change that we all want to see. So thank you for all you do to try and save life and limb, and also helping those who have lost a limb to live a better quality of life. And I think that that's where we're going with the discussion and your research today. So thank you so much, Dr. Dave. As we talked about before, that I'll call you for now, but Dr. Dave Bosenquat from South Wales, thank you so much for joining us. Before we get started with the actual research that you want to share with our listeners and our viewers right here on the UK Hangout, tell us how you ended up with what we are calling a foot fetish. Why your passion with all of the areas of vascular surgery? Why PAD?
Well, first of all, thank you very much for having me on. And I do wonder if maybe if I can share my slides, I share that, give you a story about that, if that's all right.
Of course, of course.
So let me. And I'm hoping that that's come up now.
It has.
Fantastic. So, no, thank you very much. As I say, my name's David Bosenquat. I'm based here in Southeast Wales. And I'm going to show a couple of slides of intraoperative operations, and in part that will help me answer this very question of yours. So the next challenge is to make sure it clicks forward. This is, hopefully you can see that now. What I've got on the screen is on the right-hand side, somebody whose foot has gone really bad, but on the left-hand side,
and we
you
should warn that if you do have any sort of squeamishness to the reality of PAD, make sure to turn away, and we will let you know when you can look back. But go ahead and listen in, because we're going to learn a lot. Back to you.
So on the left-hand side, we've got a cut near the skin, over the skin of the ankle, near the skin of the ankle. And you can see zoomed up a tube. And if you look very closely at there, this is actually a vein that's been harvested from this patient. The artery by the ankle has been identified. And an operation has been done, a very delicate operation, and you can maybe even make out those tiny little stitches of the suture material that's been used to join the vein to the artery. And this is what we do day in, day out when we are trying to save limbs. We're doing bypass operations. And to get to your question,
Is this a DVA?
No, this is actually just a distal bypass. This is
A regular bypass.
distal
Okay.
bypass. But I still remember as a surgeon in training. I was probably second year, and I saw a bypass like this in the theatre. And I remember the operation starting, and they clamped up the arteries, and they did all the sewing. And at the end of maybe about 3 or 4 hours work, they released the clamps, and blood flowed. And I thought, that's amazing. That is simply amazing. And so simply the technical challenge of it, but also the fact that this is even possible is really very impressive and amazing that we can do these things. But the honest truth is, and I'm going to push a slide, my next slide has also got an intraoperative photo, is that sometimes you need to do an amputation. And so this is a photo on the left-hand side of a patient who very sadly has had to have an amputation. This is above the knee. And what I've shown you here is how that we have to cut the nerve. And the nerve is this structure which is held on this metal clip for the first and second photo. And next to the nerve is being put a little catheter for local anesthetic. And this is what this study is all about. I'm going to move on to my final slide. There's no more intraoperative photos, so please feel free to look back to the screen if you have been a little bit squeamish. But this takes me to amputation surgery. So where I would say that my passion from an operating point of view is to save legs, is to do those complex bypasses. I think that they are technically challenging and rewarding, and they're a fantastic benefit for the patient when it's successful. The honest truth is that sometimes you simply cannot save the leg, either because the bypass is too complicated and it just won't work, or because the damage within the foot is too significant. And so we end up needing to offer amputation surgery. And the problem with amputation surgery from a surgical perspective is that we failed. We have failed to save the leg. And so what happens is that I think that because of that, it's seen as a failure. And there's very little research interest around this area. There's a lot more interest in research around saving legs and what can we do. But when it comes to the actual amputation itself, it's been devoid historically of any high quality research. So I was going to stop sharing at that point, and hand over to Grace if it's an appropriate time to do so.
Yeah, that's fine. Thank you. I've just got a slide as well to share. So as Dave mentioned, we're doing what will be the largest randomized controlled trial in the UK of amputees. So we are aiming to randomize 650 patients who have undergone lower limb amputation surgery. So that's either above knee, below knee, or through knee amputation. And they'll be randomized to either receive the nerve catheter, as Dave showed in those last photos, or standard of care, which in the UK is varied. So in some hospitals, it is standard of care to have the nerve catheter placed, but in some hospitals it isn't. So for our trial, we're saying standard of care is not to have the nerve catheter placed. That's the control group. And then the intervention group is to have the nerve catheter placed. And we're comparing pain. So patients reported pain for the first 5 post-operative days. And that's just a simple 0 to 10 scale. And that's taken twice daily by the research nurses. So once in the morning, once in the afternoon or evening. And that's going to be our primary outcome measure. So that was basically the most important thing for patients that we talked about this study when we were designing the study and applying for funding for the study. That was the most important thing for them, was their pain management. And also we're looking at other outcomes at 3 and 6 months. So are they able to walk with an artificial limb, and their health related quality of life and healthcare costs and things like that. So we started recruitment in October 2023. And since then we've activated 20 sites around the UK.
Oh, wow.
So this is just a map of where all the active sites are in the black dots. And then we've got 2 grey dots. So we're open in Wales, England and Scotland. We've still got a site and set up in Northern Ireland who we're hoping to open before the end of the trial, but we're not sure if they'll be able to get there or not. And another one in the Midlands who we're waiting to open as well. So most sites have randomised at least 1 participant. Our highest recruiting site is in Bristol, so just next to Cardiff in the southwest. They've got over 60 patients at their site. And we're currently at just over 360 participants, so over halfway to our target of 650. That's all for that slide. And then this is just our contact details if you did want any more information about the trial. There's the trial email address, Dave's email address, and my email address.
And did you want to share the video as well that you said that you have for patients?
Yes, thank you. So this is the video that all the sites that we activate have access to. We send them an iPad, and they share that with patients who may be eligible before they undergo their surgery. The patient information leaflet is quite long for them to read through. So this is just a 90-second video, which patients can watch and decide whether or not they want to receive more information. So I'm just going to try and share that window with you now and hope that this works.
This is a randomized controlled, so the patient doesn't know whether they've received it or not.
Well, they will know actually, yeah. So it is randomized, but it's not blinded in the sense that,
Gotcha.
Yeah, so they will, they'll either be attached to the IV drip, because the drip connects to the catheter at the end of their leg, and that's in place for up to the first 5 days after their operation. We don't have a placebo. It's not placebo controlled, so we don't hook up a catheter and then infuse saline or anything as a control. We just they either have the intervention or not, so they will know which group they're in.
Can you click the full screen button on the right-hand
Oh,
side
will do,
under?
yeah, sorry. Yeah.
There you go.
And then hopefully this is going to play.
There.
We're not getting sound, Grace.
You might have to reshare it again and add
Sorry,
sound. That's okay.
let me pause this.
Oh, good. So this is going to explain the entire what's happening. So because that's what I was going to ask you next in terms of that nerve actually the one that had that was a nerve that you had to clamp on.
That was a nerve that I had a clamp on, yeah.
That's very large. That's larger than I thought. I pictured nerves going through your body that are just really small. It looked really big.
This is a common sort of discussion that we have when people who aren't who don't do much operating come, you know, they're trainee surgeons, for example, they come to the operating theatre, they're surprised at how big the nerve is. But you can imagine that it is so important to make sure that what you deal with that nerve when you do an amputation correctly. And as I was saying, we just don't have the research base to tell us what is the best thing to do. Is it best just to cut the nerve and inject a bit of local anesthetic with, let's say, a needle, which is very simple? Is it to put this more complex nerve catheter? And because amputation research has been ignored, we just don't have good quality data on which to base practice. And so that's why this is so important. And as Grace said, as and when we do hit our 650 patient target, that will be the largest ever amputation randomized controlled trial done. So there will be other trials which are potentially bigger that include amputation surgery patients, but not specifically just focused on those types of patients.
Wow. Okay. She's going to try and share this again. Just make sure you click at the top right, include sound, and then it'll include it.
Whilst Grace is sharing that, maybe I could just take a time to just briefly talk about the Limbless Association, which some of the audience may be aware of. It's a UK-based charity for amputees. And we've actually been supported by the Limbless Association since the outset. And one of the fantastic things that we've been able to do with the Limbless Association support is to be able to offer to every single participant of the placement trial engagement with their peer-to-peer support group. So when we speak to patients, they say to us things like, well, you're a surgeon, you can tell us about the risks of surgery, you can tell us about the dressings and the recovery and the pain and tablets, but actually what it's like to live life as an amputee, you know, we do best to hear from people who've actually been in that position already. And the Limbless Association do this fantastic thing of buddying up someone who's undergoing surgery with somebody who's already been through that. And because of this sort of synergy with them, we're, like I say, able to offer this to every single person enrolled onto placement.
Yeah, that's great. So that's part of it, that part of your study includes the community aspect of it, the buddy system.
Yeah, exactly. And obviously patients are perfectly free to accept or decline that offer. But we know that there is a significant benefit from being able to speak to somebody who's been there and to be able to answer those questions that we just don't really know the answer to because we don't have that lived experience.
And what we have found, though, is you do have a lot of Facebook groups, for example, that support, you know, peer-to-peer support, but we've always found that there needs to be still some supervision, facilitation of the conversations, because, you know, one person could take another one on a downward spiral. They may start, we found that so many patients start trying to give medical advice to other patients, and they don't know. On the surface, it may seem as though they have similar presentations of disease, but not every amputation is the same. There's different places they cut. It might be an above knee, but it might be more distally versus proximally. And they might have different life experiences. And sometimes they don't know, you know, those guardrails as to, you know, here, this is the support I need to give, stay out of these lanes. And so we try in our groups to make sure to help facilitate those conversations and make sure they don't end up in the wrong direction. And we have a couple doctors. We should add you to our Facebook group as well for the UK. And Grace, so you can help us support the patients. I think it's really important to have physicians and clinicians involved.
That rings very true. No, absolutely. Um, I guess that the value that they can add is that shared lived experience, but yes, absolutely, there's got to be that caution about giving medical advice.
Yep. And different people have different lived experiences. Some have an easier time based on their athleticism to get in and out of the shower, their different needs for the chairs. We have found that we've gotten, the same chair for, a few people and it only works for one. It doesn't work for the other two. And you're like,
Mm.
well, you all are above knee amputees. Why isn't this chair working? But different people, different experiences, different housing situations, different finances. I mean, so many things, some have help, some don't. And so um, I'm sure that the Limos Society, they probably have a full training program, as part of their buddy system, I would imagine, like a peer support training program to help them understand how to best guide someone by
They
sharing their
do.
experience.
They do, yeah.
Yeah. I would love to see it just because I think that would help us as well. We've been asked for general P.A.D. for patients to be buddied up with other patients with similar experiences to be able to share. So I would love to see that training program to see how we can, emulate something like that, or even ask them if we can use theirs.
Yes, yes.
Okay. It looks like we have the video ready. Are we ready?
I'll try again. Yeah, let me know if you can hear the sound.
Managing pain after amputation surgery is important and helps recovery. The placement trial is seeing if nerve catheters affect pain relief after leg amputation surgery. Nerve catheters are tiny tubes placed next to a leg nerve during surgery. Local anesthetic is given through the tube for 5 days after surgery. Different pain medications have different side effects, risks, and benefits. Nerve catheters may or may not affect pain relief after surgery. Nerve catheters may or may not affect long-term recovery. Few nerve catheter studies have been done before, so their use varies. Placement is seeing if nerve catheters are safe and effective for pain management. If you take part in placement, you will be randomly selected to have a nerve catheter placed or not during your surgery. All participants will receive pain medication for any pain they may have, which can be increased as needed. We'll ask questions about any pain and side effects you may have for the first 5 days after surgery. We'll also contact you in 3 and 6 months to ask about your long-term recovery. Taking part in trials like this helps improve future patient care. Thank you from the placement team.
So I'm wondering, can you walk us through what it means to place a nerve catheter?
It's a relatively straightforward procedure. So part of the amputation surgery will be identifying the nerve, and traditional teaching will state that you have to make sure that the nerve is divided high, away from the operative field, so it doesn't get embedded in the inflammation when the amputation skin is starting to heal. To place a nerve catheter, all you do is you put a needle and then you thread a little tube just next door to the nerve, and then you pass it outside the amputation stump away from the incision site. So it's a similar piece of kit which people use for epidural infusions. That's what sometimes people have as a tube into the back to provide anesthetic for an operation or procedure. It's exactly the same kit we use. And then after that, it's simple to connect it to a local anesthetic pump. And local anesthetic is what you use for your teeth if you go and see the dentist. The idea is it may numb pain and take away pain in that acute situation.
So the tube is it's actually visible on the outside. How do you remove it at a certain point after 5 days? Does it just slip out? What does that look like?
Yeah, absolutely. Because it's not stitched in at any point, it's easy to pull out. So some of your listeners may have had a Venflon tube in the vein for like a drip, and you will know that it's very easy. You take the sticky off and you pull out. And so it's the same idea for this nerve catheter.
So it's while they're in the hospital, and how many times a day is it administered? Is it just once per day for 5 days?
It should be on a continuous infusion. So you've
Oh, wow,
got
okay.
an option of putting it in an infusion pump, similar to how you would have fluid on an infusion pump into your vein, or you can use what they call these elastomeric pumps, where you fill up a device and it will slowly over time squeeze down and deliver a constant stream of local anesthetic that way.
So is the idea that, in picking the time frame, um, what went into picking that time frame? Is it that based on experience that the first 5 days are the worst, and so you're planning to just get them over this initial hump, or is it just that the first 5 days after an amputation, that's typically how long the hospital stay lasts?
Well, in the UK, the median length of hospital stay after an amputation is 22 days. So
Oh, wow, okay.
they are definitely, and that's because it takes quite a long time for them to get their house in order, to get the wheelchair ordered, all these kind of things which need to happen, and it's a long time whilst in hospital. But to go back to the sort of clinical side of things, we thought that 5 days was a balance between not too short and not too long. We
Yeah.
obviously don't want it too short, otherwise we're unlikely to see an effect, even if it does produce a pain relieving impact. But there's also a risk of infection whenever you have plastic tubes entering and leaving the body. So you can't leave it in indefinitely for weeks and weeks at a time because of the risk of infection. And if you have an infection in an amputation area, that can be catastrophic. And let's say that you had a below the knee amputation and got infected. Worst extreme, maybe that moved to an above the knee amputation. So these are really serious things that we have to try and balance out. And so 5 days was a sort of pragmatic choice, really.
And is this both for below the knee and above the knee amputations? Are those both included in the trial or just above knee?
No, we'll include both below, through, and above. So
Okay.
through knee amputations are reasonably uncommon, but no, we'll include all types of major amputation.
Is there anything preliminary that you have been able to um, understand, maybe where this is going in terms of the outcomes? Is it so far what you thought?
They're very careful to blind everybody except for one
Uh,
safety group with any sort of results, and I think that's really important because otherwise it can bias what people are likely to do. I will, by sort of just thinking about, what are we learning as we're doing the trial? What we're learning is that a number of centres, their anaesthetists before the operation will also do local anaesthetic injection using ultrasound. So that's with a needle through the skin, and they'll be targeting the groin nerve. And so whilst placement won't necessarily answer that question directly, does an ultrasound injection help or not help? It will provide a little bit of bit more evidence to sort of hypothesis generate. That's what we call it as, to sort of say, okay, well, look, maybe we are seeing a trend of this or of that. Amputation research in terms of pain is such in its infancy that,
yeah.
the honest truth is that I can see us having to look at something else after we finish placement. This won't be the end of it. This is just the start of it. And if we find that there's an impact, well, we'll say, well, that's great, but what's the next thing we can do to help? And what's the next thing we can do to help?
And Kathy has a couple questions. I don't know if Kathy wants to jump on. I know that Grace has jumped in and answered them, but maybe some of our listeners might have the same questions. So Kathy, if you wanted to ask or you want me to ask, I'm more than happy to as well. But it looks like she's not unmuting. So she asked, can any amputee contact the Limbless Association and get peer support, even if they haven't been on your trial?
Yes, absolutely. And so that's the sort of routine way that amputees find out about that. But it was very patchy. So in certain areas of the UK where you had proponents of that, the team would give out the leaflets, please contact them, please contact, and in other areas it wouldn't. So the idea with placement is then it becomes standardized essentially, and these 18 to 20 sites which are open. So you certainly can. And the other thing that you can even speak to people before you may have amputation surgery. Sometimes people are weighing up, do I, continue as I am, maybe with painkillers and dressings, or my surgeon's offered me an amputation. So what do I choose? And that can be really difficult. And so again, you can contact Limb Association in that scenario.
And she also asks, what is in the infusion used in the non-nerve tube group? The same painkiller is in both?
Yes. This is sort of what you were asking, I think, Kim. What happens to the group that doesn't have the nerve catheter?
Yes.
And the answer is that they have the standard care, which is that you cut the nerve and you might inject it with local anesthetic, but you don't have any plastic tube. What we try to do is figure out what's happening in the real world, right? Within the UK, when we started the trial, a little over 50% of patients who are having an amputation would have ended up with a tube. And why would they ended up with that? Not because there was good evidence, because the surgeon thought that it was worthwhile doing. And then about half, just under half of patients wouldn't. It would be a simple cut. The operation would be quicker, maybe less risk of an infection, but we don't know if those two different ways of managing the amputation results in different degrees of pain. So we were very careful to try and compare two real world treatment options when we were designing this randomized trial.
And so the goal is to create a standard that improves the quality of life for these people and reduces the pain, because obviously there is an incredible amount of pain from my experience with these patients with an amputation, and not many painkillers can really cut it orally. So this could be really helpful. And I'm guessing that's kind of what you found as well, which is why you're interested in this.
Exactly. We have a fantastic patient representative. He's called Dave Cox, and he had both legs amputated, and one was with a nerve catheter and one was without. Just so happened, he was operated on by two different surgeons over a period of time. And he's publicly spoken. Both him and I went to BBC Radio Wales to talk about the placement trial a few years ago. But it's fantastic to have those kind of insights from these people and these individuals who've undergone both of these. But like I said, we do want to know if this technology works or if it doesn't, because we have to keep an open mind that maybe it won't impact it as much as we think it may do. And then we look to say, how else can we help? How else can we improve things? There's lots of scope to improve pain outcomes in amputees.
Did Dave Cox have any opinion as to which one felt better?
Now, his impression was that the nerve catheter did help with pain. And so you sort of pick up on these stories here and there, and anecdotal evidence to think, yeah, well, I think there's probably reasonable enough suggestions to think that it's worthwhile doing a randomized control trial in this area.
And we had someone who shared in our group recently a documentary that talked about, and I forget what it was called, talked about how amputations have not changed. The process by which a limb is amputated has not changed since the Civil War, which to me was really surprising. And I'm curious your thoughts, and how just the process of just an amputation has evolved over time, if it has.
It's probably very true what has been said there. The technical aspects of the amputation hasn't really progressed much, and I think it's because it's a surgeon's blind spot. And yeah, for the few that are interested in amputation surgery, it's been a challenge to get the wider community engaged and interested. So probably from some of the surgical techniques which happened those years ago are the same. Now, the anesthetic techniques may be significantly better, and obviously we're much more sterile, and the pre and the post-operative care is very similar. But, for example, from an above-knee amputation, I wouldn't be surprised if it was very similar in terms of technique. I will, if it's okay, just pivot slightly, talking about the fact that it's so important to get the wider surgical community engaged. I'm fortunate enough to chair what we think is going to be the first true international guidelines on amputation surgery. It's the European Society of Vascular Surgery. So those guidelines will come out in 2027. And so it is, having gone through that process of drafting these guidelines and the text that goes with it, I can say with confidence that there is a lack of good quality evidence on which to base these guidelines that we should be providing for clinicians. But once the discussion starts, once the discussion is out there and people realize that there's a bit of an absence and realize that we've had a bit of a blind spot, that is when I think the surgical community will sort of catch up and we'll hopefully see more research within the amputation sphere.
One of the things that I know with our amputees that we struggle with, and we just there's nothing out there for these patients in terms of prevention of another amputation, prevention of the revolving door for that leg, even with an above knee amputation, and prevention of losing even parts of the other leg and becoming bilateral, right? AKA amputee or BKA, either way. In terms of the exercise, you still need to move that stump. How do you move that stump? What can you do? We've seen so many patients that have been recovering for those 22 days, right, in the hospital, and they're laying down, they're not doing as much as they would normally do. And so their alleged good leg starts to turn bad because the legs mimic each other. And so have you heard of any research that's being done on that? Any advances or any programs that are available in the UK that are there or being worked on to help improve the circulation for these amputees?
Yeah, thank you. I mean, basic secondary prevention is got to be stated first. So if people are smoking, I know it's an addiction, I know it's really hard, but that's really important to stop. And taking tablets which are good for blood vessel health, that's really important as well. We get physiotherapists to support us in the recovery of amputees. And one of the key things is for the amputee to be able to stand on that remaining leg and to be active and to be practicing transfers and to be sitting out of bed. And probably one of the most important things is to have that positive I can do it attitude. I mean, it must be absolutely devastating to go through this, absolutely devastating.
Yeah.
But if patients can come with that attitude of, this is really tough, but I'm going to make the best of it, and I'm going to get out of bed and I'm going to sit in bed and I'm going to give myself realistic goals every day, maybe once or every week, every month. What are my goals going to be? How am I going to get to those goals? How am I going to get my prosthetic leg fitted as soon as I can? Because I've got goals that I've set that are realistic, that are achievable, that I want to motivate myself for, to make sure that I'm not laying in bed for those 22 days. And as soon as I'm in a position to get an artificial leg, on it goes and off I go.
What is typical for over in the UK in terms of for a P.A.D. patient and getting a prosthetic? Because here in the US, more than 60% of amputees do not get a prosthetic in the first year.
Yeah, that's really interesting. So previous research that we've done is something called Perceive, and this is partly based on this, on the fact that surgeons can be quite over optimistic in terms of saying what their patients are likely to get in terms of artificial limbs. And we are probably not good enough at providing realistic outcomes. You know, your figure of less than 50%, I think that's very reasonable. The chance of walking with a prosthetic leg is better if you've got a below the knee amputation, and if you've got an above the knee amputation, better if it's a one side rather than both sides. And the younger and the fitter that you are, the more likely you are to ambulate. So for example, an above knee amputation, somebody aged, let's say 80 and above, it's unlikely to be able to ambulate. So no, the figures that you quote are probably very akin to what would happen in the UK. I think that would probably be very similar to that.
It's interesting that you say that someone with a below knee amputation has a greater opportunity to be ambulatory versus someone with an above knee amputation. And yet here, I don't know in terms of the UK if it's the same, but here we seem to have a lot of doctors who think that an above knee amputation is the better option for most patients. And our philosophy based on our medical advisory board is that if you have a patient and you can do a below knee amputation, it's better for them because they can get a knee scooter and be more mobile versus especially in the coming months following the amputation, versus someone who with an above knee amputation that will end up in a wheelchair until they get their prosthetic.
Yeah, absolutely. The pros of the below knee compared to the above knee are obvious in terms of ambulation, and they are there. And so, typically speaking, people would choose a below knee if at all possible. The challenge is that the failure rate of a below knee is higher than an above knee amputation. And so, if you have somebody who is struggling to withstand an operation because maybe their heart or their lungs are struggling with the anesthetic itself, it may be that even though technically you could do a below the knee amputation, they can't tolerate a second operation, or you think that they're likely to really struggle if they have to have a second operation. So you choose what you think is the safest operation for them. And whenever you're faced with something like this, there's no correct answer, so to speak. There's a shared decision to be made with the patient. And what my job is to go and to give them as good information as I can, and all the various options. And together we work through that and try and reach an agreement. And oftentimes I call on the support of my prosthetic and rehabilitation colleagues, because it's so helpful for them to come along as a fresh pair of eyes to support patients in those uncertain cases, to help choose the appropriate level.
Multidisciplinary approach. That's a new concept. I love it. No, it's so true. I hadn't even thought of it. What a great idea to check in with those that do deal with the patients and the recovery aspect of it, to say, hey, you know what, I'm not sure really on this patient. Would you mind doing an assessment and help us to determine the right course of action for this patient, whether it's below knee or whether it's above knee? I know that the arteries, one of the reasons that one surgeon says why he rarely does below knee amputations is because it's just quicker healing for everybody, since the arteries are larger above the knee versus below the knee.
So you are right. So the healing rates for above knee are better than the below the knee. What we typically say is that if you have blood flow to the thigh artery, which originates from the groin, if you have sufficient blood flow to there, you should be able to heal a below the knee artery.
Yeah.
For patients who suffer with diabetes that causes hardening of their arteries and peripheral vascular disease, they typically get lots of hardening in the vessels in the calf region. But what that does mean is that there's typically sufficient flow to heal the below the knee amputation. So yes, we always consider blood flow when it comes to the amputation site selection. And so if somebody had a major blockage from, let's say, their belly button down of the arteries on that side, nobody in their right mind would offer a below the knee amputation.
Yeah, we still have some doctors that just don't believe in treating the arteries below the knee at all. If a bypass is not possible, then they will not take a wire or balloon down there. And so every single patient does end up with an above knee amputation versus, there still is P.A.D guidelines say that you should try to restore inline blood flow to the point of amputation. So they're like, well, we could restore blood flow to above knee, so we're just going to do an above knee, versus other doctors may say, we know how to take a wire and balloon, and we're going to at least try. We're going to take a wire and balloon through the popliteal into the TB trunk, going down just a little bit further, and see if we can just eke a little bit more blood flow so that a below knee amputation will suffice. And I'm sure you see that variance in care because you do have quite a few sites, quite a few different doctors, quite a few different approaches, and I'm sure you experience the variances every single day.
You're right, and nobody has a monopoly on the truth. No one has an absolute monopoly on what the right option to do is, and so that's why I think it's so important to speak to the patient. Some people want to play things very safe, and they just want the safest procedure and the safest operation, and they don't want any further risks. But if you explain it to various options to certain patients, they will say, no, I want to try this. I am prepared to give this a go, even if there's a reasonable chance of failure or even a high chance of failure. And I mean, if you think about, I've spoken to a lot of patients over my time, and, sometimes you speak to patients and you say, I'm really not sure we can do much to save this leg, but I could try, it's tenuous. And people often, they divide themselves up. There are some people who have had enough and they just want to have the amputation. That's it.
Yeah.
No, we've been through this enough. And yet there are others who say, no, I'll be prepared to do anything to keep this leg. The idea of an amputation is anathema to me. It's terrible to me. I want to keep my leg, if at all possible. And so you support your patients as much as you can to give them the various options. You reach a shared decision making. I think that decisional regret, that's what you don't want your patient to have.
Yeah.
You want the patient who chooses for an above knee to say that was the right thing for me to do. And you want the patient who chooses to try and save their leg, even if it doesn't work, to say, look, I'm glad I tried. I'm glad I had that option. I'm glad I tried.
It's interesting. Our 2024 Vascular Surgeon of the Year is from Spain, Marta Lobato, and she was sharing the story of a patient that, the patient said, you know what? I know that I'm destined for an amputation. I know I'm going to lose my leg above the knee. Like, I get it, but I want you to go back in there and I want to try things that you've always wanted to try, but you have been afraid to try because of the risk of amputation. Because I want you, as long as you don't increase the amputation, as long as you don't increase or put my life at risk, I really want you to go in and use me to learn from, because it's hereditary in my family. And I want to make sure that my kids and my grandkids and my great grandkids all have options and a better chance than I did at, keeping my leg. And I thought that was really an interesting approach. If someone's going to lose their leg anyway, then why not try? Why not try and learn something along the way and through the process?
Yes, I mean, I guess in practical terms, that does occasionally happen where you have something where you can push the boat out and you can say, look, this is a tenuous option, but let's say it's a young patient who's fit, whose heart and lungs can withstand multiple operations, who's desperate not to lose a leg.
Yeah.
And then what you do is you say, yeah, okay, let's do the best we can, as long as we've got support from colleagues, so that it's an agreement that it's not completely curveball. And as long as we've got agreement from the patient, let's go and do it.
Yeah. So, well, we appreciate you so much for all you are doing to help people. There is, as you said, so much, and we're so grateful with all the research and the advances in care for limb salvage. But there are still situations where amputation is treatment. It's the only treatment. It's the best treatment to lose your leg to save your life. And we get it, or to improve the quality of your life from where you are, instead of having a revolving door of procedures every 6 weeks to try and just keep eking open those arteries, which is just not realistic. I mean, you don't even get your teeth cleaned that much, right? But there are these patients that are just clotters, diabetic, heavy diabetic, and it just keeps clotting. And until you just remove the problem, it's going to continue to be a problem. And that's not a quality of life, with a revolving door of these procedures every 6 weeks on top of wound care and more wound care and being sedentary. Um, and we need more research to help these patients get back to their life. And I love that you are, taking the bull by the horns and saying, hey, you know what, we got to do something. None of us want amputations, but we got to help those that it becomes a reality for. And so I'm curious, just as we close out here, what other interests do you have? So I imagine that this is, you started in 2023. You probably have a few more years to go, because it seems like they're trickling in, with the one in Bristol giving you the most patients, but you want to get to 600 patients, which I'm assuming you're not quite there yet.
We're going to be going this recruiting for at least another year. And then we've got lots of follow-up data, because we're capturing pain outcomes up to 6 months. So it's not going to be for another couple of years before we get definitive results out there. But it's interesting, you talk about other areas, and one of the things that I very briefly mentioned on was a through the knee amputation. And it's an amputation operation which is done infrequently, but it's interesting, from experts around the UK and from international experts, there is a repeated voice which says that we should consider the through-knee amputation, because for certain select patients, you're going to get better outcomes than for going for an above-knee amputation. So that's actually a randomized controlled trial just started from being led from Hull, from a colleague in Hull, looking at this exact topic. But no, I think that'll be a very interesting area to look at in terms of amputation surgery in the coming years.
Explain the through knee. I need to visualize it. So you have the below knee, of the above knee. What is the through knee, right?
Well,
Through the
imagine
middle?
if you were to kneel down,
Okay.
it would be the imagine, and you're sort of kneeling on your knee joint essentially. When you do a through knee amputation, you're left with what you would otherwise be kneeling on. So you don't cut through any bone. You simply divide the leg at the level of the knee joint, and it's a pretty uncommon amputation operation, which is something that I've been keen to introduce locally and nationally, based on repeated very positive feedback from my rehabilitation colleagues, from my prosthetic colleagues, and physiotherapy colleagues. So they are telling us, they're saying, look, if you can do it on the right patients, you can get significantly better outcomes.
Interesting. We'd love to have him on to come on and talk about it, and also be able to include that trial on our PADtrials.org. So we're going to be getting all of your sites up, hopefully, on it very soon in the next couple of days. Did you send me the actual sites, a list of the sites?
I can do that. Yeah, it is on our
Okay.
website, but I'll do that as well.
That'd be great. And I'll include all of your information. We'll include this video so people can learn more, and send me the link to that separate video as well if you want me to share that video with some folks. But PADtrials.org is where we're placing all of these trials. Hopefully we can democratize access to those who may not have any options in the United Kingdom. And I'm glad that you have so many different sites that are involved in the trial as well. And thank you so much for all you do. Is there any final thoughts before we close out here? We would definitely love to have you back again to answer more questions from folks. I'm sure this will stir up a lot of interest in the UK.
Well, I'm just delighted that you've had us on. Thank you so much for sort of letting us champion our cause. It's really impressive what you guys do and the community that you pull together. And so it's just great to be able to be part of it. So thank you very much.
Thank you so much.